who has spoken at our conference on several previous occasions. He's, are you chair of orthopedic surgery at Rady?
I'm just the program director.
Program director at Rady Children's Hospital in San Diego and professor of clinical orthopedic surgery at UC San Diego, and the David Sutherland director of the Cerebral Palsy program at Rady and program director of the education program there. You're one of the original Botox investigators and overseeing a movement disorder clinic as well as a lifespan disability clinic since 1992. And your son, who has cerebral palsy, is now 35 years old.
I know.
Wow. Welcome back.
Thank you so much. Thanks. Well, thanks for having me back. It's always an honor to come to this great conference. Yesterday, I flew in from the American Academy of Orthopedic Surgery meeting in New Orleans, and we were learning how to put the screws in the right place and all that stuff, and I walked into the transgender talk. I go, I'm not in Kansas anymore, Toto. This is a different group of people. When I was visiting professor in Melbourne, Australia, I was challenged by my host to give a more personal talk than rather a technical talk. And so I'm going to talk a little bit about our family and how it affected me and how it affected the way I think about cerebral palsy. How many people in here have family members or themselves have some sort of developmental disability? And the rest of you went in it for the big money? Okay. All right, great. Is this the advance? I'm sorry. Oh, here it is. All right, so I'm going to talk about cerebral palsy view from both sides. And these are my disclosures. I'm not going to talk too much about it, but there are some off-label use. Botulinum toxin, at least some of the ones like Botox that you've heard of, has not been approved for use of spasticity by the FDA. Dysport, however, recently was approved for lower extremity spasticity. I talk about intrathecal baclofen. It's not approved for the use in dystonia, and it's the best thing you can do for dystonia. However, when you think about it, 50% of all the drugs that we use as pediatric specialists are not approved for use in children. So we do these things off-label all the time. Every day you do that. What is cerebral palsy? And there's a lot of different definitions. When I was a resident, I was taught that it was all due to obstetrical trauma. And if you go look up, as you all know, if you go Google cerebral palsy now, you'll find all the best lawyers. They're actually pretty good sites, but they're all lawyer sites. And they'll tell you, have good pictures and tell you how to sue your doctor, sue your obstetrician. Was the baby too big or too small? And one of the things that as we get together as a group and come up with consensus, we feel that it occurs before the age of 3. I can't believe I'm talking in front of Marshall, and she's going to tell me everything I'm doing is wrong. The world's best epidemiologist. So I'll probably misquote her several times in this talk. And then this is a thing that our academy, American Academy of Cerebral Palsy and Developmental Medicine came up with a definition. And really, you all know what cerebral palsy is, so I don't have to go into much detail, but that it's a non-progressive disturbance of the brain. And I may argue a little bit against that from some of the things that I've seen in my adult practice, but it affects everything. So I'm not going to read that whole definition, but it affects everything in the body. So epidemiology, and you notice I call this the cerebral palsies. There's no such thing as cerebral palsy. There's no one disease or one entity. And a lot of some of this work is from Eve Blair in Australia. And so the risk is much higher if you're born prematurely, if you're very small, and 1 in 3 children with a very low birth weight will have CP. However, as you saw today from Yvonne's slide, most of the children with cerebral palsy are not premature. It's maybe a little bit more than half. And there you can see that number there. The prevalence, and this is from Marshall's study, showed that in 3 states, 3 to 4 patients, the prevalence is a little bit higher than we have been talking about, 1 to 3, and now it's probably 3 to 4 patients. 3.8 was the number. And so there are about 10,000 new diagnoses each year. About 1 million people in the United States have cerebral palsy. One of the things is we've been more successful in the NICU and also taking care of children as pediatricians, is that we have a longer survival rate. And there are now more adults than there are children with cerebral palsy. There's also some racial differences, which we aren't really quite sure why that is. It probably has to do with availability of services in the prenatal period. But 54% of Americans have some sort of disability. In fact, everyone in this room, at some point in your life, will either be disabled or dead. Think about that. Right? You're going to be in a walker or crutches or a walker or a wheelchair, or you're going to be dead. If you look at the entire cost of a child with cerebral palsy across all levels of severity, it's about $1 million. So this is a huge impact on our medical system. The etiology of the cerebral palsies, I'm not going to go through all of these. Mainly, it just shows you how complex cerebral palsy is, and that there are so many different types. The thing that I'm just going to, once again, because I'm bringing a little bit of my family into it, and that is this hemostatic disorders. So we talked a little bit in the EPO talk about how it can cause increased clotting problems. My wife was pregnant when I was an intern, and we found out we were going to have twins. About halfway through my internship, one of our twins died in utero. And when he was born, when my other son was born prematurely because my wife had an abruption, we found out that the other child's umbilical cord was completely clotted off, and that was the cause. We go, that's really terrible, bad luck. And my son has really bad, GMFCS Level 4 CP now. And then 20 years later, my wife got several blood clots coming back from a trip over to Europe where we sat on the ground for a long time. And it turns out that she has factor V Leiden, the heterozygous type, not the homozygous type. But if you think about it, about up to 5% of American women have this as maybe a cause of seizure disorders, or not seizure disorders, but stroke problems. And so that's where we found out where my son had this. There are some other interesting things in here, and Yvonne talked about these as far as chromosomal and brain abnormalities. Many of our GMFCS Level 5 patients, the more severely involved patients, have some sort of chromosomal abnormality. And as we just got a $120 million grant at Rady Children's in San Diego, and we're doing more genetic testing on all these patients, and we're finding things that you've never even heard of. It's just a series of numbers, and then I'm supposed to figure out what to do with that child. And I think I'm glad I'm at the end of my career rather than the beginning of my career, because I don't know how we're ever going to know how to treat these, because we won't know the natural history. A big study here in Contra Costa County several years ago demonstrated that there was an increased high incidence of vaginosis in the mothers whose children had cerebral palsy. And once again, none of these things these are correlations; they're not causations, and we really aren't sure what's going on. We do know that some things like epigenetic factors, such as maternal depression, that's misspelled, and a couple of other things are happening. So just think about the brain, and remember the homunculus from medical school and from college, and think about why does this happen? Why now you can hear the simple orthopedic surgeon. There's no neurology going on here. This is orthopedic surgeons with pictures, okay? So it's the only way I can remember things. But here's the brain. You see that kind of looks like a brain. And here's the homunculus. And remember that, this gyrus here is where the legs are. And your legs are pretty stupid. They do the same thing, right? You walk, you don't do anything fancy with that. With your hands and your face, you have a lot of different things going on. So if these are the ventricles, and then remember this watershed area, and that was a thing that Yvonne talked about. If there's a area of injury right there, the legs are more preferentially involved than the upper extremities, and that's what diplegia means. The lower extremities are involved more than the upper extremities. And it can be symmetric, but most of the time it's not. And very rarely are two kids the same. And that's really hard for us to do research now because we don't know. We can't get a control group because they're not the same. They have some other problem going on. And she talked about the strokes. And then this area of the basal ganglia is really changed. Our understanding of what happens at the basal ganglia has really changed our evaluation of children with cerebral palsy, our treatment of children with cerebral palsy, and I'll explain that later as we get to that. This new functional MRI information is just beautiful, looks great. We don't know what to do with it yet. There's so many, there's all these, all it does is show how interconnected the brain is. I mean, that's the most important thing. If you look at some of these tractography things, something from the cerebellum goes to almost every tract that comes out of your body. So if you have a problem in your cerebellum, it affects your balance. It affects everything. It affects your speech. It affects the way you walk. It affects the way you talk, the way you use your upper extremities. And so we're learning this, but this becomes very complex, three-dimensional things. So Yvonne talked a little bit about some of these preventive strategies, and obviously that's going to be our hope, is to not have a child with cerebral palsy. And she talked, as you can see, we could talk an hour about every single one of these things. And she talked about some of those. And, I think most of us believe that this is an inflammatory problem, particularly in the premature children, and maybe in the HIE patients. And so what can we do? What kind of anti-inflammatories are we going to be able to give, whether that's cooling or EPO, all kinds of things. There are some children that are born with hypothyroidism. It has to be tested or you won't be able to treat it, and that's an effect on the brain. We talked about the EPO and other things that are erythropoiesis stimulating agents. Avoidance, having our mothers avoid toxic substances, of course, is important. There's the assistive reproductive technology has changed. So probably 10 or 15 years ago, we would have runs of quadruplets and quintuplets from this reproductive technology. And I think the obstetricians are much better at it now, so they might be able to implant at least at the most twins. And so our incidence went down. At one point we had 6 quintuplet sets in our NICUs, and two of them each had, of all those, 2 of them had cerebral palsy. So I'm still taking care of those families. And of course, remember I told the cerebral palsy goes up to the age of 3. So anything you can do, like to prevent non-accidental trauma, near drowning, and those things that cause brain injuries. It's very similar to cerebral palsy. So how did I get into this field? When I was in medical school, I was very interested in pediatrics. I thought that's what I was going to do. And then I got very interested in orthopedics, and then I found out there's a thing called pediatric orthopedics. So that's what I was going to do when I started medical school. So when I started my residency. So this was before my son was born. But we were going by with my wife was pregnant, and we saw a United Cerebral Palsy telethon. And she goes, "What's cerebral palsy?" And I go, "Oh, let's see. I learned that in that same class where I learned about muscular dystrophy and myasthenia gravis," and so I made up something. And I did, in my pediatric rotation, I only had one patient with cerebral palsy the whole 2 months I was on that as an intern. And then when my son was born, when I was an intern, and this is him, and he weighed 2 pounds and 9 ounces. My residency taught me everything that was wrong. And unfortunately, I still see this going on across the world and across the United States. Is one of the things, we just lengthen tendons. Orthopedic surgeons just lengthen tendons and see how they do. Put them in casts for a long time. And that's what I learned, and that's what my son had. He had all these surgeries. My son's had 29 operations now. And I would say 20 of them were bad. And I pushed them. So that makes me feel even worse. I was very fortunate to do a fellowship in San Diego with Dr. David Sutherland, who became famous here at UCSF and at the Shriners Hospital. He was one of the inventors of the field of gait analysis, and I was a very forward thinker in the way that we do surgery. And so I was very lucky. And the other thing is, for those of you who are younger and are getting into this field, I think it's very important to get into some sort of one of the organizations. And so I started off in the American Academy of Cerebral Palsy, went to meetings, got to meet everybody, got on committees, eventually was the president of the organization. Right now I can call anybody in the world if I have a question. And those are really important. And unfortunately, my inbox is filled with people asking me questions right now, but it also is great. It's a good thing. So what is gait analysis? I mentioned that because of Dr. Sutherland, and this is really an important field. So it's, as I told you, every child is different. And so there's different ways to do gait analysis. I can just watch a child walk back and forth, write down my observations. I can take a video on my iPhone and save that. My hospital won't let me do that, but my iPhone's filled with them. And the other thing is to do what's called three-dimensional gait analysis, where you can measure what's going on in 3 dimensions, and then make your decisions based on that. If those of you who've never seen gait analysis might have seen some movies where gait analysis was used, like every Pixar movie, every Disney movie was made with gait analysis. Steven Spielberg sent his team down to our lab for 3 weeks, and we showed them motion capture and how that works. And we go, oh man, we're going to get research money. This is going to be great. And we took them out to dinner. We did all kinds of stuff. And then they ended up saying thank you, and then they went and bought 20 motion capture systems. And that's when they started making the Pixar movies. So we got nothing out of it. But I do enjoy those movies, so I guess that's good. Classification systems, the diplegia, quadriplegia, hemiplegia system is very poor inter-observer reliability. If you look at my own chart, someday I'll say the kid has severe diplegia, and the next day he has mild quadriplegia. And so it's really hard to, these don't work. One of the people a famous neurologist who popularized this, he didn't come up with it, but he popularized this. Anybody know? Sigmund Freud. So Sigmund Freud's, one of his big interests in research was cerebral palsy. He wasn't a psychiatrist, he was a neurologist. There's a thing in Europe where they talk about unilateral versus bilateral. Talk about simplistic. I really don't like this system at all. It doesn't make any sense. Anybody who's taken care of a kid with hemiplegia knows that they're not unilateral. And so, and now there's been many studies that show that that's wrong 25% of the time. So that's not a very good system, I don't think. Using this household ambulator, therapy ambulator, community ambulator, those are good things. Kind of gives you a picture of the patient, but it doesn't tell you much about it. And what's revolutionized the field of cerebral palsy is the gross motor functional classification system. And this is derived from a test called the GMFM. And this is what many of you are therapists and know how to do this. It takes a while. You have to ask a lot of questions. You do tests. You come up with a score, a number. And you take that number, and the group in Canada just started putting these out and plotting these, hundreds of patients, and realized that they came out in 5 pretty close groups, and came up with something really complicated of how to figure out what they are. And of course, orthopedic surgeons get a hold of it and make pictures and make cartoons. And so these cartoons are great because that's how I remember it, and hopefully the way you'll remember it too. So a level 1 patient is someone who hardly has anything wrong with them. They may be a little bit uncoordinated, might be the last kid picked on the baseball team. There's something, there's just something different. A level 2 is someone who has problems on uneven ground, and in a first world country, the way you can tell is they're wearing an AFO. Okay, that doesn't work so much in Haiti where I go, or Jamaica, but if they have an AFO, that tells you they have GMFCS 2. A level 3 is someone who uses crutches or a walker, can use a push themselves in a regular wheelchair, but usually a walker. Level 4 is someone who's in a powered chair, or someone who can walk in therapy. And then a level 5 is someone who needs complete care and is in a wheelchair most of the time. And so this is really an interesting thing, because if you just use the word spastic diplegia, that could be almost this entire group. It could be anywhere on there. And I have about 20 papers that I just need to throw away that I wrote, because I used, in fact, first our Botox patients were all GMFCS 1s. So here's the interesting thing about this is if you do anything to a child before the age of 6 or 7, anything, physical therapy, early intervention, Botox, any surgery, they're getting better. That's the natural history. They're going to improve no matter what you do. So all the kids in the first Botox studies were under the age of 6 and GMFCS 1. And surprisingly, they all got better. What a miracle drug that I'm such a great doctor. And but anyways, so when we look at the GMFCS and how it revolutionized things, everything that we do is almost directly correlated. It's not even logarithmically, it's directly correlated to their GMFCS. And these are the things that we do in orthopedics, including things like morbidity and mortality. The GMFCS is not an outcome measure. It's just a classification system. But if you want to do something to see if you can improve how what they're doing in the gross motor functional area, is to do this thing called the functional mobility scale. And that's what happens, that's what the child can do at 5 meters, 50 meters, and 500 meters. And you figure that out, and then that's what you can say that by doing this intervention, they improved from using a walker, or from, say, using a wheelchair at 50 meters, and they're now using a walker. So that's a helpful, that's something that you've done to improve their outcomes. Now that's just the gross motor functional classification. We also have I have nothing to do with it, but people have developed scales for the upper extremity called the Manual Ability Classification System, very similar. There's now a communication system. So this is really a great way to communicate and also for us to do research. So if you tell me this person is a GMFCS level 3, and then you tell me what they do at 5 meters, 50 meters, 500 meters, you tell me how they use their upper extremities based on this, and you tell me how they communicate, I have a great picture of that person in my mind. And I can also if I'm doing research, I want all those patients to be in that group. And so it really has changed our field. Very simple thing. Now we talk about the dimensions of disability, and you saw some of this yesterday, and all of you are familiar with these, but the International Classification of Functioning Disability and Health, or the ICF, looks at body functions and structures, activities and participation, and environmental factors. And so this is the model that we base all of our research on, and also what our goals are as taking care of children and adults with disabilities. So I can work a little bit on body and function and structures. My goal is to get them to participate more, and then I have almost nothing to do with environmental factors. That's usually something that the government does with curb cuts and accommodations at work. And so this is when I was in San Antonio as a junior faculty member, and I started the Challenger Baseball League there, and I also started the Challenger League in San Diego. And so this is a baseball thing where the kids come out, and this is my son, Sean, and his little brother. And this is him just last week. He's in a drumming circle. You can just see the joy that he has. And so that's our goal, is to get your patients and your son and everybody out doing stuff. I wish he was that happy all the time. That's a different story. We'll talk about that later. The other one is this is actually my favorite. It was made by the NIH, and it's NCMRR. And it puts a person at the center of this. It could be anybody. It doesn't have to be, when I give this talk to orthopedic residents, I say this could be someone with a hip problem that you're going to do a total hip on. And it looks at the different dimensions of that problem. And it looks at the pathophysiology, what caused it. We talked a little bit about it. What's the impairment, which means what's happening at the cell level, for example, spasticity. How do we treat that? We look at the functional limitation. Those are what does spasticity do for you? If you're walking, you have a hard time walking, you have a hard time speaking, you have a hard time using your upper extremities. Your disability, or what are your roles in society? We all have different roles. We're students, teachers, husbands, wives. Think of every role that you have. How does that disability impact those? And then the societal limitations are, what does our society put in as far as way of curb cuts and attitudinal approach, problems of way we treat people with disabilities, as we learned yesterday in the ACLU talk. this was kind of thrown out mainly because almost all the words are negative. Disability, functional limitation, impairment. And that's where the WHO kind of came out of that with positive language. I mean, just because it's negative doesn't mean it's not good. So I like it, and it helps me think about different things. So we come up with different paradigms, and we all have to set goals. And it's really important that these goals are collective and realistic. So when you sit down with a family to decide whether it's therapy or some drug, Botox, orthopedic surgery, I'm not going to cure your child's cerebral palsy. And if that's what you think your goal is, then no one's going to be happy. And so we have to set the goals. We have a team. You all are this team. I have a thing. My first thing I did in the CP Academy, this is like 1991 or something, they asked me to put on the family forum, which is the first one that we had. And so I brought all the people who were specialists to come and speak to the audience in San Diego. And I stupidly put 32 people on the stage. Because that's how many people impact. If you think about speech therapists, physical therapists, gastroenterologists, it was a great one. We never replicated that because it was just ridiculous. And then the management of movement disorders, we'll talk about that, and the different therapies. What's the role of technology? Most important thing, of course, orthopedic surgery. Not really. It's the least important thing, and then we'll talk about that. So we have to set goals, and this is a study that was done about 20 years ago. They asked, the question was, these are asked young adults, what's the most important thing in your life? The first one was independence. And I think that's true of all of us. Who wants to be living with their parents? Who wants to be independent? The next one was to have a job. In one of my earlier slides, I showed you that 75% of people with cerebral palsy are unemployed, even if they have skills. Communication, just what we're doing now, just talking, exchanging ideas. Activities of daily living, brushing your teeth, going to the bathroom, just taking care of yourself. Mobility, getting from point A to point B, very important. And the least important of all, drum roll, was walking, which is what I do all day, trying to get people to walk. And so that's, we're actually doing a study right now where we're asking the parents the similar thing. I haven't looked at the data yet, but my guess is it's going to be completely opposite of this, right? The first one, all they care about is walking. I went through that when my son couldn't walk. That's one of the things you give up. I mean, it's really a horrible thing when you realize your child can't walk. And so you go backwards, and the last thing anybody cares about is independence, as we learned yesterday in conservatorship, or guardianship, if you're not from this state. So we have an integrated approach for children with cerebral palsy. I'm obviously not going to go through all of these, but it's important. It's just a big team that we work together and come up with the answers. So. A lot of you here I know are therapists, so occupational therapists, at least in the field of cerebral palsy, are the ones that take care of upper extremity and oral motor problems. Talking to you is a joke, but I do give this talk to orthopedic surgeons. Speech and language is very important. The management of drooling. So this is a kind of an interesting, the kids who are GMFCS 3, 4s, and 5s often have drooling. Does anybody know which federal agency has spent the most money on drooling research? Oh, see, you're not supposed to answer it. It's NASA. And gosh, you usually get Department of Defense or now the White House. But actually, that's us watching TV at night going, seriously? So when you go into space, you drool. It just goes all over the place. I've actually been to 2 NASA drooling seminars. And the story they told me, because my son had a real bad drooling problem, when Gemini, we had Mercury, they went up and they came down. Gemini, for the young people who don't know anything about this, that's when they sent 2 people up and they stayed up for a long time, like several weeks. And not knowing that when they took their helmets off, this drool just came out all over the place. They didn't know, it was just, they didn't see it. Except for as soon as they came back in the atmosphere, it came all over their masks and just 2 weeks of drool all over everything. And so now they have ways to stop that. And anyways, in fact, the first thing they have to do on the space shuttle is wake up in the morning with a little vacuum cleaner and find their little drool things and pick them up. Because it can get in the instruments and short it out. The other thing we don't think about is, this is a brain injury, so there's visual problems. And if you think about, we have a child with hemiplegia, just close one eye and see when you bring your other hand over, when do you actually see it? It's pretty far, it's almost midline before you see it. So if you have this kid that you're working on, you go, why aren't you using your hand? He goes, he doesn't even know he has a hand. And so that's a real problem. Besides the fact that there's a motor disorder there, they don't know that, they forget that they have the hand. So and the other one is you can have a field cut, inferior field cut. So if you're walking, you can't see the floor, it's going to be hard. You're going to have a really hard time walking. So physical therapy, there's a lot of different physical therapies. We can talk an hour on each of the different things. Everyone in this room, of course, knows what hippotherapy is. None of the orthopedic surgeons do, even though the picture's right there. And those glasses now are back in style. Although women wear them. I saw them on the plane yesterday. They were all just girls wearing. So just know that they're back. And the other thing that physical therapists, I think, are really great at is managing equipment. I mean, those of you who are therapists know that. You know the equipment much better than we do, and what will be helpful for them. So that brings up the field of technology, and there's a promise and challenges. A lot of people say if we just gave a lot of money to technology and threw everything to it, then things would be great. However, there's a lot of challenges with technology. It's very expensive. These things can't be mass produced. So there's not that many people that need them, so that it becomes very expensive. Training is really hard. So my son had the Dynavox. Do y'all use the Dynavox? Remember using the Dynavox? I could never figure that thing out. That is just like, you have to have like a PhD in communication. It's, anyways, I'll talk about that in a second. But there's training, and then there's upkeep. You have to upgrade it. Things break. And of course, the insurance company might pay for the first one, but they won't pay to fix it, as you all know. And many times we have to do specificity for each child. And then you as therapists know that's your job to keep that going. Someone said, what if we have robotics? Wouldn't that be cool? We could do really cool things with robotics, and maybe there may be something in the future. And this is the Locomat. Many of you have seen these before. They cost $1 million each at least. And so we're using them for kids who are GMFCS 4, right? So the kids who are really non-ambulators, and maybe the GMFCS 3 kids. I'm not putting it down because I think it's good to get exercise and things, but is it really going to change that person's life? Are they really going to go from a GMFCS 4 to a GMFCS 3? That's very rare for that to happen. Our goal as clinicians is to keep someone in their GMFCS level. So if you see someone dropping from a 3 to a 4, your goal is to get them back to the 3. And that could be from surgery or physical therapy or something. Your goal is not to make them go from a 3 to a 2. That just doesn't happen. Maybe occasionally, but it doesn't happen. However, this one right here, using a child that has athetosis and using a computer to modulate those extra movements so they can use a computer, those are going to be very helpful. So I think there's a lot of things that are coming along. Speech therapy and communication devices, you all know how important this is. I told you where it was in people's hierarchy of needs. And this is, so we went from this Dynavox, which cost like $8,000. I had one, which we never used. And then in all these very simple ones, one of my friends, our friend Richard Elson in New York, he had the Leapfrog or the Leap for the Frog, something or other. He sold that to Dynavox, but he was smart enough to know that the market was about to crash because no one at Dynavox had heard of an iPad apparently. And so he made millions of dollars, and then they went bankrupt like a couple months later. So he's very smart. But this is where we are now. An iPad's $500, and you can get it's usually about a $400 application to put on it. And so we've had really good luck with that, and the speech is very good. Our mobility is getting from point A to point B, and this is usually just means different types of assistive devices. And it also shows how bad public transportation is for people with disabilities. I mean, at least in San Diego, I can't speak for everywhere, but almost everywhere I give this talk, they all agree. It's really hard to get on public transportation. This is a controversial area. Especially I'm talking to a room with therapists in it, so I'll have to remember what I'm talking about. So a lot of people, everybody wants to get people standing, and their goal is to improve a lot of things, the bone density, GI function, urologic function. There's all kinds of good reasons to stand, and I agree with that. However, when the studies were actually done with DEXA scans and things at Boston Children's, you have to stand for at least an hour and a half a day to get any improvement in your bones. That's a lot. An hour and a half a day is a lot. And no one knows if it affects, they don't have a long-term to know if it affects fracture or fragility. And if you look at how some of these kids, particularly the GMFs 4 and 5 kids, are standing, they're standing on their groin. There's no weight going through those legs. So the area in your pelvis is probably pretty good, and that area never breaks. But but you just wonder about what. And so when I tell someone that when they want to go into a standing program, I ask them, do they like it? And if the kid likes it, and they like to do things upright, I think that's really good. Because I take care of adults, and I still had some people that were taking 4 other adults to lift this person into a standing frame every day, and the person hated it. And so, because I said, well, it's going to affect his bones. He's going to break his bones if we don't. And I don't think there's any evidence that shows that that's true. Wheelchairs, we go from the simple sling chairs to the custom power chairs. Don't ever use those for anything but transportation. Any of the sling chairs. I mean, you all sat in one of those chairs, the ones they take you out of the hospital with. I mean, if you sit on those for more than like an hour, your leg's numb and they're not very comfortable. But it becomes very expensive. And we go all the way up to these very expensive things. I know you all know this because you work in the field. How much do these cost? Yeah, my son's cost $35,000, the last one. So, but he has to tilt in space because he has GI problems. And so everything, it just becomes very, very expensive. And if you think about that. Transportation, there's not very many of these. This is from Columbus, Ohio. These are very expensive. I'm on our 4th one of those. How much do those cost?
20 to 50,000 for not before the van.
Yeah, after it's converted, it's about 50. Yeah, 45 to 50. If you get an FM radio on it, it's like 50. No. Yeah, so they're very expensive, and that's the problem. Most of our families can't afford this, and I'm an orthopedic surgeon, I can afford it, but it's not readily available to everyone, and they're hard. If you get them when you can get them used, that means they're almost worn out, and the shocks are bad. Everything's bad because you add all that extra weight. So we talk about the medical management of cerebral palsy, and it's not just the motor problems, all those things we talked about before. And I just list all of these things here because my sons had all of those. And unfortunately, I had to diagnose most of them myself because no one picked them up, particularly the gallstones and the kidney stones were missed. So we talk about movement disorders and the importance of how we treat these. What is spasticity? You know the definition of spasticity? Y'all treat it every day. What is it? Do you guys know what you're treating? What is the definition of spasticity?
Involuntary muscle contraction.
Yeah, that's not it, actually. Yes, sir.
Intermittent rigidity of muscles and tendons as they move joints.
Yeah, that's not it either. Yes. Yes, it's the reaction of a muscle to a rapid stretch, to a rapid movement. What you're talking about is dystonia, and I'll talk about that in just a second. So this is, and what's the best way to test it? Big hints on the board. That's how you rapidly stretch a muscle. You hit the tendon and you stretch it, and that's how it works. Chorioathetosis, what is that? Oh, come on, this group. There you go. There you got it. You got it back there. It's the marionette movement, and that's great. So that's very good. I appreciate that. How about ataxia? How do you know if someone has ataxic? So every time you either walk with a really broad base, or every time you walk, the next step is different from the one before it. I know none of you have ever seen anybody drink alcohol, but if you have, that's what ataxia looks like afterwards. So it's every step. Maybe you might have had alcohol before. I just came from the American Academy of Orthopedic Surgeons in New Orleans. I saw a lot of ataxia come in. In fact, my son, who's now a chief resident in orthopedics at the Cleveland Clinic, came in at 2 a.m. yesterday with quite ataxic. And then dystonia is what you were talking about. Dystonia is the posturing. You get your muscle in a different position and you posture and turn the heads and you see this and you'll see this in the kids. And this is a really critical thing, and it changes how we take care of kids. When I give this talk to orthopedic surgeons, I go, why do we care about any of this stuff? This is what neurologists do. But if you have a child that has dystonia, the worst thing you could possibly do for that kid is to do an orthopedic surgery on them, to lengthen their tendons. You'll make them much worse. My son has dystonia. And the other thing about dystonia is it doesn't show up until they're about 6 or 7 years old. They're not born with dystonia. And then it gets worse during puberty. And so you might miss it. And so we sometimes do surgery in little kids, and then you screw them up. So I would say 10 of my son's surgeries were wrong because he has dystonia, including the selective dorsal rhizotomy. So this is just a bigger picture. And this is really for the stupid orthopedic surgery, but hopefully you guys will pick something out of it. So if I were to cut your head off, you would just be a reflex, okay? As you walk, you would rapidly stretch your gastroc. It would go back. That's your stretch receptors in your muscle. It would go back through your spinal cord, and right away you'd pop back up on your toes. And that's what equinus is. So a kid with equinus is doing that. What comes from the brain are inhibitors or modulators of that reflex. And that drug or that neurotransmitter is GABA, gamma-aminobutyric acid. So what do we do? What are things that we give that are GABA agonists? Valium, baclofen, those are GABA agonists. What can we do in this to stop this reflex arc? We could put botulinum toxin into the muscle. That stops this thing. We can do selective dorsal rhizotomies, and that's all to break up this reflex arc. So this really simple idea explains how all of our treatments of spasticity works, just based on this. If you remember that spasticity is the rapid stretch. And so here's a child with ataxia, just to show the movements. You can see it's wide base, sometimes they're different. Here's a child with chorioathetosis. I think you can see how she has a hard time walking. Here's a child that has both dystonia and chorioathetosis. So there's the movement, and you'll see his arm just kind of go into full extension there and just keep his arm stiff. And that's the dystonia part. So this really changed our field of understanding spasticity versus dystonia. And so when you tell me someone child has spastic quadriplegia, that's probably not true. There's spasticity there, but most of them have dystonic. They're usually dystonic cerebral palsy, and that's a huge difference. And this is a picture of my son when he was. This is in his baseball league, and actually that person is his roommate today. They're now 35 and 37 years old, and then this is him. He was so rotated from his dystonia. He couldn't use his computer anymore. He couldn't drive his wheelchair, and he asked me at this age to take him to the operating room and kill him. And his life was so miserable. And so this comes down to this area. It's called the basal ganglia. And of course, as an orthopedic surgeon, I will spend an hour explaining these to you. Now, I have no idea what they are, but they're somewhere down in the brain. But there are other problems that happen with cerebral palsy that we forget about is the loss of selective motor control. So two children look exactly the same. They have the same amount of spasticity, but if you ask them to reach for something and grab it, they can't. And the one that's the most common is someone that has hemiplegia that has a drop foot afterwards. They can't fire their tib ant, even though they have a tib ant, the tibialis anterior muscle. We forget the sensory deficits that happen with strokes for kids with hemiplegia. They have, they may not feel their upper extremity, they may not feel their legs. And then last is weakness. And we really didn't appreciate how weak children with cerebral palsy were weak until we were able to manage their spasticity. You can stand up a kid with spasticity and dystonia, and they just stand there and you go, look how strong that kid is. And then you manage that, and they're just as weak as you possibly can be. And so what do we do with physical therapy and managing spasticity? We can do physical therapy, and those of you who've had a massage know exactly how you feel for about 15 minutes afterwards, and you go, why did I spend that much money? It was great, but now I feel tight again. And then these are the drugs that we use. So we use diazepam, we use baclofen, and for kids who have dystonia, we can use this drug called Artane. I haven't had good success with it, but there are some people that use it for all their children with dystonia. The big problem that I've seen with this is really severe nightmares. So the kids just want to quit taking it because their nightmares are so bad. We can put phenol or alcohol right on the nerve, and that dissolves the myelin sheath, and that breaks up once again that reflex arc. And then we can use the botulinum toxins, once again are off-label, but I've given over 20,000 injections now. And now I have 6 physiatrists that work with me, and that's much of what they do. And this new thing, this cannabis CBD oil, I think there's really some hope for that. I have some families who are using that, and the problem is we can't study it. Jeff Sessions said he would put me in jail, and really my hospital won't let me do it because we're worried we're going to lose our federal funding if we study it. So I can't even study it. So it's really, really kind of sad. I can prescribe it, but I can't use it. So in orthopedic surgery, we can lengthen tendons. That lengthens that reflex arc. It changes that reflex arc, but it only lasts for about 6 months. We can actually cut the bones to rotate them. That lengthens some muscles and shortens some muscles. We can cut nerves, which we never like to do because they often come back and it doesn't work very well. And surprisingly, if you fuse the spine in some of these kids who have really bad dystonia and athetosis, it improves them. We don't know why. There's some central control of that, and I think that's why. The big thing that's changed our care, particularly of dystonia, is the intrathecal baclofen pump. And that's where we place the pump in the muscles underneath in the abdomen, run a tube around the back and into the spine, and you can run it all the way up. If you want to get the upper extremities, you put it up there. If you want to get if you want to get upper and lower, if you just need lower, you do there. My son had the highest one put in at the time. It's at C2, and really changed his life in several ways. It got rid of his dystonia completely. He has none. He's just floppy now, which is great to help take care of him. But he still has he has motor control. The bad thing is it affected his swallowing, and he got pneumonia, which put him in the ICU for 6 months, and he had to have a feeding tube placed. So those things are all things you don't think about, but in retrospect, if we ever lost this, his quality of life would be so bad. You can do a selective dorsal rhizotomy, and so these are kids where you cut some of the afferent neurons that go back to the spine. That breaks up the reflex arc. You cut about 30 to 40% from L1 to S1. And you improve, or from L2 to S1, and it decreases their spasticity. However, these are only for kids who are pure spasticity, premature, have good trunk control, and are probably level 1s or 2. Okay, they don't work for everything else. So of course, my son's a 4, he had a rhizotomy, and because of that, he had horrible lordosis of his spine. I'll show you his picture of what happened, and actually had spine fractures from being in this lordosis. So another unintended consequence made by your father. So this is him before the surgery and then after the surgery, and you can tell how that baclofen pump helped. Deep brain stimulation seems like it'd be a really positive thing. The center of research in this area is here at UCSF, and my patients that get this come up here for that. It hasn't worked so well in cerebral palsy, because there's such a diffuse injury. It has worked well in kids who have what's called DYT1 dystonia, which looks like cerebral palsy, but it's an inherited problem. So in orthopedic surgery, we want to do things called single event multi-level surgery where we operate on do as many operations as we can on one day. So I'll sometimes do 20 operations on one day on one kid. And then they go through all the rehab and all the pains out of the way. We use epidural catheters, and then they start their rehab period. And that's a new change, and there are still places in the world that don't do that. You want to delay the surgery as long as possible, so greater than 6 years. And we want to manage their spasticity as well as doing their surgery. And so this is a paper that we wrote, and Roz Boyd is the lead author. And I can guarantee it's true because we made it up in a bar one night. And it's published. It's published, so it's got to be true. But it really is just a philosophy. So when they're really young, you use Botox, botulinum toxin, and physical therapy and braces. As they get older, you add casting to that. There's more casting. And the only time we do something different is if their hips are coming out at any age, we put their hips back in. And that's our philosophy. A lot of people don't do that. And the people who don't do that don't see adults. And I've had an adult clinic for a long time now, almost 30 years. And I see what happens when your hips are dislocated. And there's no good way to fix them once they're out. So we put them in at any age. And I know there'll be people in here, I saw some people shaking their heads already, but we do that all the time. And then we do this casting, and then we do this single event multi-level surgery, 8 to 10 years old. And the other thing that you notice is when you get older, it's really hard. The surgery doesn't work as well as you get older. So there's this sweet spot right here where we can intervene and change their life. After that, it's really salvage type things. So we'll go through level 1 these are the high level kids. Many of them have seizures. They may be on the ASD on the spectrum, as well as having this. This is from my friend Kurt Graham in Melbourne. Very little things. These kids may need botulinum toxin. Don't need anything else like intrathecal baclofen, and it's mostly a therapy kind of thing to take care of. And level 2, this is spastic diplegia of prematurity. These kids have a lot of gait problems and can get significant deformities, but they don't get scoliosis, and they rarely get hip problems. So these are the kids. If very few of them will benefit from SDR, but botulinum toxin is important. And this is where we do a lot of our orthopedic surgery, and this is a single event multi-level surgery. These are the kids that are using braces, and like I said, I can have an hour-long talk on almost every one of these slides. Level 3 are the kids that are starting to get dystonia. So dystonia is coming in the picture. It affects how we do the surgery. It affects on what we use. These are the kids we might use an intrathecal baclofen pump, but usually it's orthopedic surgery. We look for their hips coming out of joint, which is when this really starts happening, and we start looking at their spine at this point as well. And so this is where we do the operations where we cut the bones, rotate them, put these plates, and do these pins here. And then level 4, the patients we're starting to see the non-ambulatory patients. And once again, much more dystonia. This is the time we start using intrathecal baclofen. Scoliosis and hip problems are much more prevalent during this group. And we do, in our surgery changes, before we were doing surgery to improve their ambulation. And now we're doing surgery to improve their comfort and sitting. So these are different. Now we do different operations. Before the GMFCS, I guarantee you, I've got papers, you can look them up, where I did operations to get kids walking who were GMFCS 4s at age 10. I mean, it's just stupid. I mean, you just shouldn't even do that. So, but I've got papers on it. And some of them got better, but almost all of them are just sitting now. And so once again, this direct relationship between hip displacement and their GMFCS level. 90% of people, GMFCS 5, will have hip problems and need to be addressed. And that tells you about how you should screen them and when you should take x-rays. And so here's the sockets not forming right, the hips coming out of the joint. And then we've done CT scans showing that if you're a sitter, your hip comes out the back. So that makes sense. If you're sitting, your muscles are pulling your hip posteriorly. And so we do surgery to fix the valgus of the hip, which is meaning the hip's going upward, and then also for rotation, which is femoral anteversion. And so these are the operations that we do. Here's a kid with hips both out. Here they are with the hips back in. Another kid, same thing, hips, here they are with their hips in. Long-term follow-up on that one. So GMFCS 5s, these kids have multiple medical comorbidities. They have almost all of these kids have dystonia. So we treat these. 90% of them will get hip problems and scoliosis, and our goal is comfortable sitting. Also managing these comorbidities. So we have a lot of these kids get all kinds. They're seeing all the other doctors, the gastroenterologist, the neurologist, pulmonologist. And our goal is to do preventive surgery so we don't have to do salvage procedures. We also start thinking a lot more of the caregiver quality of life. We think about it all the time, but this is really a tough time for families with a child with GMFCS 5. And so we do these things to address the hip, and these are all salvage procedures that we don't want to do. These are kids whose hips are dislocated and no one picked them up, and these are the things that we can do. None of these are good. This is a 13-year-old kid whose hip was coming out. There's no cartilage on this hip left. Okay, can you imagine how painful that would be? And so isn't this a very cool operation where we just cut the hips out? It's terrible. It's a terrible operation. Total hips, you go, just put a total hip in. Very high complication rate and very difficult to do. There's a lot of complexity in doing that. One of my friends in DuPont in Wilmington is putting shoulder arthroplasties in because these kids are so small that a shoulder will, you could put a shoulder there and that would work. I'm getting ready to publish this study. This is where we inject botulinum toxin in the muscles around the hip and have had great results with pain relief for up to 6 months. So it's an expensive way to treat it. But not more expensive than going in the operating room. Just walking in an operating room costs $15,000. And so if I use 400 units of botulinum toxin, that's what's that, $2,000 or something like that, $3,000. So it's much cheaper than doing surgery. This is my son's foot after my partners did all these terrible operations on him. And he had this ulcer. And so I came in the operating room and told him how to do the right operation, and that's his foot now. So we fused the MTP joint and we lengthened his tendon. I'm joking about that, but no. His foot does look better now. And so we fused joints for stability. In the spine, we have all these different deformities, particularly things like scoliosis, and this is my son's surgery. Here you can see his baclofen pump, and you can see these rods and things in there. So this is very common in the kids who are GMFCS 5. Now, once again, I could talk an hour about each one of these things. There's all these things that are called alternative treatments or unconventional treatments, and I'm not going to spend much time on them. But a lot of these are entrepreneurial based, and just because it means that we didn't come up with them as doctors, so that means they must be wrong. But there might be something to some of these, but most of them have not been shown to have any good long-term outcome. Caregiver stress is an important area to think about it because you're not treating just the child, you're treating the family and you're treating the parents. There's a much higher instance of back pain. I've had 3 spine surgeries, but I probably blame that on football and being an orthopedic surgeon, but I did lift my son a lot. And but so there's higher instance of back pain in parents who give kids with cerebral palsy, increased mental strain. There's a paper that was written that said 85% of parents with cerebral palsy are divorced. And I go, gosh, I just don't see that. And then when I wrote a paper on this caregiver stress, I found that person just made that up and put it in a book. And the statistics are no worse than regular marriage, which is 50%, still pretty bad. However, mothers usually give up their jobs or their careers. There's sleep disorders with the child. There's sleep disorders with the parents, particularly. My wife has probably not had a good night's sleep in 35 years. There's sibling stress. Although it's interesting, if you look at a lot of the literature on siblings, they go into caregiving fields, which is really interesting. Like I said, my son's going to be a pediatric orthopedic surgeon, so it's kind of interesting. The other stress is something that Yvonne brought up today, is that we have all these new treatments that are very expensive and have no evidence. And what are you supposed to do? And I was guilty of that. We used the selective dorsal rhizotomy, but the stem cell treatment is what everybody wants now. And people go to Mexico and Germany and China to get these, as you all know. We're going to talk, I have a whole talk on transition, so I won't go through this, and I won't talk about some of the adult issues, but I have a huge adult clinic. And one thing I want to bring up, because I'm going to bring it up again, is the huge mental problems that people with cerebral palsy have. 45% of my patients have bipolar disorder. And it's not because they're depressed because they have a disability. They actually become manic, where they don't sleep for 7 days and are hitting out and reaching out to people. This is a different problem, and this is something that we haven't noticed that much. I end with two things. Just like, and I've been through these, and just like when someone in your family dies, you go through these stages of grief, of shock, denial, anger, bargaining, depression, testing, seeing if there's any realistic solution, and finally acceptance. And every one of our families goes through these at different times. Some of them never get past anger. And some of them get to acceptance when the kid's 2 or 3 years old, go, okay, this is what it is, and this is what how I have to live. So what have I learned in my 35 years? There's always, people are seeking for a cure for their child. Simple insights led to great changes in care. Dystonia, the GMFCS. There's almost no money available for research, as Marcelin will tell you. And as we went to Congress, lobbied. You didn't get to go because you work for them. But we got to go, we went to Congress. Huh? I did, yeah. And we got $60 million. And then it got sequestered. And nobody knows where it is. And Tom Harkin retired, and so we don't have anything. There's no money. There's a huge disparity between health care for children and adults with disabilities. Treatment's important, but as Yvonne was saying today, prevention is the real hope. And all of you are my heroes. You have, especially those of you who have no vested interest other than taking care of this population. So I'm going to quit here because I have some more from the next talk. But thank you.